Hello, doctors. This is Dr. Bruni again, your friend, your brother, and your guide in this Canadian practice journey. Look, I just want to know where you are joining me from, and quickly, let's sort this out. If you can hear me clearly, kindly type yes, 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 I can hear you before we get into class. Please let me know if you can hear me clearly, okay? Before we get into the class, because we're going to dive right in, and I want to make sure that we getting things right. So please, if you can hear me, if I'm loud enough, let me know. So that awesome. Okay, so Dr. Lankela says I can hear you. Beautiful. So let's jump in. Invite your friends, share the link to as many friends as possible so they can all join and we can all study together. All right. So we are streaming live on YouTube, we are streaming live on Facebook, and if for any reason um you want to watch the replay, in fact, the replay of all the live classes we've been doing are on YouTube. Okay, many people don't know how to access it. So what let me do this. Let me just go to YouTube and show you how to do this because it's very, very important. Okay. So I'm just because many people don't even know how to find all the past classes we've done on YouTube. They are there for you for free. Just go there and review it. Okay. So let me just show you. If you go to our YouTube channel right now, okay. If you go to our YouTube channel right now, I'm just going to share my screen. Let me see. Okay, share screen. Okay, good. So if you go to YouTube, okay, this is what you're going to see. So if you come to MedCognito, okay, all you need to do is you click on MedCognito and then you go to live here. You go to live. If you go to the live, you realize that all the live classes we are doing. So today's class is here, and then you realize that the class we did on cerebrovascular accident is also there, the COPD. So it goes all the way, and depend on how you want to do it. Maybe if you want to start from the last class we did, like the oldest class, you just click on oldest. It will switch it around. It will take you to, what we did 9 months ago, okay, where we did best approach to TDM. So if you're writing a TDM exam, you can go there and evaluate it. There are some classes on Nakoski as well that we've done. So these are all videos there for you to review. They are there. We are not taking them down. They are there for you to review. And today's class is here. You will also realize that there are some videos we have. So if you go to, for example, videos here, if you click on videos here, so you will see a lot of, this is where we post all the student testimonials and all the other tips, right? So in recent times, I've started doing some opinion pieces on various things, like the quiet struggle. So doctors, we have more than 562 videos there that if you want to binge watch, and I've gotten a lot of messages from a lot of candidates who tell me that they are binge watching, our content. That's great. I want you to do that. Share the link with as many friends as possible. So just wanted to bring this to your attention that you have all this waiting for you. Okay, you have all this waiting for you in the MedCognito YouTube channel. So if you want to know how to navigate it, if you go to our YouTube channel, just click on live, and that is where every live class we've done, we don't take any of them down. You can access everything. All right. Okay, good. So now let's jump into today's class. Let's jump into today's class and then take it from there. So I'm going to share my screen. Awesome. Okay. So today's class is approach to common fractures. However, you realize that we will deal with something very specific so far as approach to common fractures are concerned. And I'm very thankful for the information. Ben Ajenim Boatin says, yes, it's clear, Dr. Bruni. Dr. Eno also says, hello, Dr. Bruni, you are not loud enough. Oh, doctors, please, am I loud or I'm not loud enough? I just want to know because I want to make sure that our audio quality is good before we jump into anything. Is it clear now? Is it clear? Because Dr. Bright says that, yes, sir, I can hear you loud and clear. So maybe if you're okay, I can move on. Okay, Dr. Norman says it's good. Beautiful. So that's exactly what we're going to do. Okay. So approach to common fractures, and I'm going to jump in right away. So if you go to the MCC objective, you realize that this objective is under trauma. Okay. So if you want to know why I am doing what I did, if I share my screen and also take you to the MCC objective itself, okay, you realize that if you also want to get the MCC objectives, we have it with us. I can send you a copy. I have a copy of mine here. Yeah, so I have a copy of my MCC objectives here. You can just send me a message right now, and after the class, I'm going to send you your own copy. The MCC objectives itself, when you look at it on the MCC website, it has more than 440 pages, right? And we have broken everything down for you. So I have my objectives here, and you can also print out yours and study with it, okay? So this is my objectives, and we've broken everything down for you, okay? So if you can see it, we've broken everything down for you very simply. We've broken everything down for you, all right? Everything has been broken down for you. So this is it, right? And you can just print it out and study with it. But if you want to know why we are dealing with this particular topic, if you go to the MCC objectives, okay, I'm just going back. If you go to the MCC objectives, why are we dealing with bone and soft tissue injuries? So if you go to under trauma, you realize that there are various topics you need to know. And if you take your time and review this, you realize that all these trauma topics fall under ATLS, Advanced Trauma Life Support. Okay, Advanced Trauma Life Support. But I have decided that today, let's deal with this particular one. So if you click on it, okay, and in the MedCognito document, this is found under emergency medicine. Okay, it's found under emergency medicine. So if you go down here, it's going to outline everything you need to know. And that's why I've always been saying that if you're preparing for the MCQ1 objective exams, make sure that you stick to the objectives. Because every Canadian exam, whether MCQ1, NACOSKI, TDM, CCFP, EM, addiction medicine, whatever you're thinking about, they have a set of objectives and they follow the objectives strictly. Okay? So if you are learning things which are outside the objectives, you are not learning what you need. But if you are following the objectives, you are good to go. So after the class, send me a message. I'll just send you a soft copy of the way we have broken down the objectives system by system. You realize that in the objectives, they have not broken it down system by system. They've rather broken it down alphabetically. So they start with A, B, C. But I know that many of us study with maybe cardiology, emergency medicine, nephrology, right? So we have gone through all these objectives and we have rearranged them so that if you pick cardiology, you know that this is what you are dealing with. If you pick nephrology, you know that this is what you are dealing with. All right? So this is what we have done for you. And I'm not going to bore you with that. But if you look at the objective book very well, let me share my screen so that you see what I mean by that. When you look at the objective book very well, where is it? Yeah, if you look at the objective book very well, so this is the MedCognito redesigned objective book. Okay, this is a MedCognito redesigned objective book, and this is how it looks like. So if you scroll down, this is under emergency medicine, right? If you should scroll down, you realize that all the topics there and the trauma, the reason why we are dealing with it is bone and joint injury. That is it. And so far as you are following that, you know you're in the right place. So why are we dealing with this particular objective today? Because it's in the MCC objectives. Simple. So I see that people are sending me messages. Keep sending me the messages. Right after the class, I'm going to send it to you right now. And how do you send me a message? My phone number is what is going below the screen. +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. I'll prefer a WhatsApp message so that I can just send the document to you. So back to the presentation. I'm hoping that this has been helpful. But back to the presentation, Why are we dealing with it? Because it's an MCC objective. So you realize that every topic I want us to treat is based on the MCC objectives. Okay. Now, the rationale, every objective has a rationale. And the rationale for this objective is that bone and joint injuries are frequent cause of musculoskeletal pain and may contribute to permanent disability or premature death. Okay. Major fractures and dislocations may be associated with other injuries. For example, this morning I was in the ER and I had to deal with a case like that. I worked in the ER overnight and I had to deal with a case like that, bilateral leg fracture, right? So these are things you need to learn. You need to learn them. And the MCC wants to make sure that you have mastered these topics. Okay, so major fractures and dislocations may be associated with other injuries, which may take priority. Unexplained fractures or injuries should alert physicians to the possibility that the patient is being abused. So you realize that this last sentence introduces another MCC objective, which talks about intimate partner violence, child abuse, and elder abuse. And if you should go into our MCC reviews on live, we've done some lessons on them. For those in the MedCognito course as well, you know that we've dealt with this in depth. We've gone in, studied it very, very well. Okay, so causal conditions. You've got to know that these fractures and bone associated injuries can come from high energy trauma, non-accidental injuries. That was what I was talking about. Intimate partner violence, false pathologic conditions predisposing to injuries like osteoporosis, ligamentous laxity. Okay. Now, the key objectives: given a patient with acute onset of musculoskeletal pain or deformity, the candidate will determine whether the condition is due to a bone or joint injury, assess the severity of the injury, identify possible complications of the injury, and construct an appropriate management plan. Now, the candidate will also recognize circumstances in which the patient may have an increased risk for fracture. So these are things I want you to start thinking about when you're preparing for your MCCQ1 exam. Doctors, are we okay? Are we okay? Let's flow. So if we are okay, just type yes, Dr. Bruni, I'm okay. And Dr. Osagi says, please, I need MCC objectives. Sure, doc. Just send me a WhatsApp on +1 306 891 5649, +1 306 891 5649, and I'll send it to you right after the class. Okay. Now, enabling objectives. So, given a patient with acute onset of musculoskeletal pain or deformity, the candidate will, number one, list and interpret critical clinical findings, including the mechanism of injury and, when required, exclusion of other immediately life-threatening injuries through targeted examination. Number two, specific sites of injury. Number three, neurologic and vascular status. That is where we'll be focusing on today. Number four, symptoms and signs suggestive of abuse. So when you are learning for the MCQ1 objective, you have to learn in child abuse, what are the signs and symptoms which point to possible child abuse? What are some bone pattern injuries which should point you to possible child abuse? And then history of recurrent falls, and then risk for bone abnormalities and or increased risk for falls and injury, and signs of pathological fracture. Now, list and interpret critical investigations, including appropriate imaging modalities and bone density testing and investigations for causes of osteoporosis, if relevant. So that's also something you need to learn, osteoporosis. So if I were you, that's also something I'll put on my list, that after Dr. Bruni is done with his class today, I'm going to take my time, whichever book I'm going to use, what I'm going to use Up to Date, I'm going to use Toronto Notes, I'm going to use Master the Boards, whichever book I'm going to use, I'm going to master osteoporosis as well. Now, construct an effective initial management plan, including applying an appropriate splint, sling, or brace, and restricting weight bearing if indicated, and prescribing analgesics and anti-inflammatory medications as required, and referring to specialized care if necessary, and choosing the correct treatment for prevention of fractures, including among pharmacologic and non-pharmacologic treatments, and provide follow-up care and address the following. Number one, duration of immobilization. Number two, return to work and or normal activity. Number 3, appropriate use of other healthcare professionals like physiotherapy, occupational therapy. Number 4, complications requiring further treatment or referral. And what are these complications? You must learn. Complex regional pain syndrome. Doctors, this is one topic you don't want to miss for your MCCQ1 exam. So when people ask me, Dr. Bruni, how are you so sure that I need to learn this topic or I need to learn that topic? I go like, look, doctors, I learn the objectives every single day. There's no single day I don't deal with something so far as the MCQ1 is concerned. I'm always learning something new about the MCQ1, reading the objectives, going through them. And that is why when candidates come to me, I don't just tell them, go and read this book or go and read that book. If it's about go and read this particular book, there are specific topics you need to cover, right? And that is why we have covered all those topics for you already ahead of time, so that you don't need to now think about what to do, okay? And one other complication you need to learn about and master is compartment syndrome. And then factors that will affect recovery from injury. For example, the patient's living situation, employment, nutrition, substance use disorder, and general health of the patient. So doctors, today I'm going to pick that complication which is so important and which can be limb threatening and life threatening. And we are going to go through that right away. That is compartment syndrome. And as you know, and as we do, we're going to start with questions. And then after that, we delve into deep concepts. So, first question. You have a 24-year-old man who presents to the emergency department 6 hours after a motorbike accident. He has a mid-shaft tibial fracture. He received IV opioids for pain control. So, for example, maybe he received IV hydromorphone or he received IV morphine or fentanyl, okay? But is now complaining of increasing pain in his right leg. On exam, the leg appears swollen and tense. Passive dorsiflexion of the foot elicits sharp pain. Distal pulses are present. What's the most appropriate next step? A, elevate the leg above the heart level. B, repeat analgesia and observe for response. C, perform Doppler ultrasound to assess arterial flow. D, measure intracompartmental pressure. And E, send the patient for urgent MRI of the leg. What is the correct answer? Is it A, B, C, D, or E? Dr. Bironke, I see you. Dr. Bironke is done with her exam, but is still studying every day with us at MedCognito. It's beautiful to see. Okay. Because you know what? At MedCognito, it's not just about learning facts. It's also about preparing yourself to get into the Canadian healthcare system, right? So, what's the correct answer here? The correct answer will be D, right? This patient has signs suspicious of acute compartment syndrome. So when you see ACS here, don't confuse it with acute coronary syndrome. We are dealing with acute compartment syndrome, okay? So this patient has signs suspicious for acute compartment syndrome, where the patient is presenting with pain out of proportion, pain with passive stretch. And while it's a clinical diagnosis, measuring the intracompartmental pressure is the correct next step if there is diagnostic uncertainty, all right? So please remember that, especially if the exam is limited or symptoms are atypical. So you can look at certain signs and symptoms and tell that, oh, the patient is getting in acute compartment syndrome. However, if you want to be dead sure, then you've got to measure the compartment pressure. Okay. Now, another question. You have a 27-year-old man with a distal radius fracture placed in a circumferential cast 6 hours ago, returns with new severe forearm pain and numbness in the fingers. On exam, the hand is swollen and tense with pain on passive finger extension. Radial pulse is still present. What's the most critical immediate step? A, loosen or bivalve the cast immediately. B, order urgent fasciotomy. C, elevate the arm above the heart level. D, give another dose of IV morphine. And E, request orthopedic review within 24 hours. Dr. Sabine, you may want to look at your answer again. So this patient was just placed in a cast, right? So yeah, we know that the definitive treatment for compartment syndrome is fasciotomy, but then the patient has a cast on, and if the patient has a cast on, you want to loosen or bivalve the cast immediately. You know what? If acute compartment syndrome is suspected and a limb is casted, the cast must be removed immediately, right? You can't just say I'm going to do I'm going to do fasciotomy when you've not removed the cast. And this can relieve external pressure and help to prevent irreversible damage. This is the first step. Fasciotomy follows if the symptoms persist. All right. So fasciotomy will follow. So you have somebody with a cast, take the cast off or do a bivalve of the cast so that the pressure is relieved. Then you can go ahead and do the fasciotomy if the symptoms do not improve. But you can't do fasciotomy when the patient still has the cast on, right? So that is why in the answer options, I wrote that fasciotomy is definitive, but should only follow after removing external compression, right? And why is it dangerous to elevate the limb above the heart? Because if you do that, it can reduce perfusion. And when you reduce perfusion, that can worsen ischemia, right? And you realize that the pain of compartment syndrome will not improve with just giving the patient analgesics. No, it's rather going to get worse and worse and worse. Okay, so now that we've dealt with those two questions, let's do a deep dive into introduction to compartment syndrome. Introduction to compartment syndrome. So you will realize that each limb is in a sheath, right? So this is the leg. So this is like a cross-sectional view of the leg, right? This is a cross-sectional view of the leg. And each of the muscle groups is in a sheath, it's in a fascia. So just look at the leg as, you know, this closed thing, and you have all these areas around it. So it's like I've cut my leg this way and you're looking at it, right? It's like I've cut my leg and you're looking at my leg from below. Okay, so we have the anterior compartment, we have the deep posterior compartment, we have the lateral compartment, and then we have the superficial posterior compartment. Now, the muscle groups are wrapped. So if you look here, okay, and I got this from Gray's Anatomy, this picture. So if you look here, okay, they are wrapped around something. Now, in every compartment, you have muscles, you have blood vessels, you even have nerves, and all of these are living happily in those spaces together. Now, compartment syndrome happens when there's a lot of pressure built in these areas, and therefore, maybe it is squeezing the vessels and the nerves, and it is cutting off blood flow. That is basically that. So just look at it, all these blood vessels, and then the pressure in here is increasing to the extent that it is squeezing them, and it is making blood flow very problematic. So Dr. Ayebene says, how is intercompartmental pressure measured? Intercompartmental pressure is measured with a probe, and I'll show you a picture of it as the class goes on. There's also a calculation we can do. I can do a whole video on how to do the calculation so you can be able to appreciate it. But today, I'm just going to focus on the critical things. Okay, so now that we've looked at the muscle groups and all those things, what are the risk factors for compartment syndrome? I'm going to start you with a question. So you have a 68-year-old man with atrial fibrillation on warfarin who presents with pain and swelling in his right thigh after minor trauma from bumping into a table corner. He denies fractures or major injury. On exam, the thigh is tense and tender. Passive stretch of the quadriceps produces significant discomfort. INR is 4.2. Pulses are present. What's the most likely diagnosis? A, deep vein thrombosis. B, hematoma formation with compartment syndrome. C, necrotizing soft tissue infection. D, myositis secondary to trauma. And E, femoral nerve compression. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? And obviously, the correct answer is B. Many of us have known compartment syndrome in the context of fracture, but today we are going to learn that other things can lead to compartment syndrome, right? Because remember, you are preparing for a board exam, and especially in the MCQE one, okay? And especially in the MCQE one, you want to make sure that you know depth. For the CDM portion, which is no longer part of the exam, you have to be very broad. But now you need to be broad and also very deep, because we can pick on one thing and ask you 1,000 questions about that. All right. We can pick on just one thing and ask you 1,000 questions about that. So, hematoma formation with compartment syndrome. You realize that anticoagulated patients are at risk of spontaneous or trauma-induced hematomas. And these can raise intracompartmental pressure, right? And pain on passive stretch and intense compartments points to acute compartment syndrome. In fact, when we get to the features, you get to appreciate it more. Now, what is the difference between compartment syndrome and DVT in a board exam? In the MCQ1, whether you are taking the USMLE, MCQ1, PLAB, AMC exam, what's the key? One of the differences? DVT can also cause swelling, but no pain on passive stretch or tense compartment. So that is the difference. One of the key differences between DVT and compartment syndrome. Both compartment syndrome and DVT can cause swelling, right? However, if you want to distinguish between the two, you realize that compartment syndrome causes pain on passive stretch. DVT does not usually do that. Okay, good. Next question. You have a 45-year-old man who is working in industrial painting, accidentally injects high-pressure paint into his hand. He presents to the emergency room 1 hour later with moderate pain and swelling of the hand. On exam, the fingers are swollen, the hand is tense, and passive movement worsens the pain. You realize that I'm talking about passive movement, stretch, right? What's the most appropriate next step? A, oral antibiotics and outpatient follow-up. B, intravenous steroids to reduce swelling. C, emergency surgical consultation for possible fasciotomy. D, CT scan of the hand to assess foreign body. And E, X-ray to rule out bony involvement. X-ray to rule out bony involvement. What's the correct answer? And doctors, while you are here with me, please kindly do not forget to hit on the like and subscribe button on our YouTube channel so that we can keep growing and we can keep helping other doctors. It's been wonderful, MedCognito is growing, and especially on so far as our presence on YouTube is concerned, we are currently at 2,615 subscribers. We want to hit 3,000 subscribers by the end of this class. So if you can help us do that, also send it to your friends, your family members, other physicians all across the world, so that they can, feed into what we are doing. Okay. So what's the correct answer? The correct answer is emergency surgical consultation for possible fasciotomy. Realize that high pressure injection injuries are often missed, and they are a cause of compartment syndrome. That's why I was saying that don't think that the cause of compartment syndrome is only fractures, right? These injuries require urgent decompression, even if the skin looks deceptively minor. Okay? If the skin looks deceptively minor, the answer is C, not B. The answer is C. Okay. So let's do a deep dive into the risk factors for compartment syndrome as well. Deep dive into the risk factors for compartment syndrome. Why will pressure build up in the muscle compartment? We saw how the muscle looks like. Okay. Why will pressure build in it? There are various causes of pressure building in the muscle compartment. One of them is if there is something filling that space. So just think about, an enclosed space. Why will pressure build in it? So what are some of the things which can fill that space? There can be bleeding into that space. There can also be swelling of that space. Number two, there can be blocking of the blood flow. So, for example, there can be an external thing which is blocking blood flow, like if you put a cast on and it is very tight. There can also be ischemia. And then there can also be burning of the tissues. So, if there's an external burn, which forms a circumferential burn, that can also do that. So, when you're thinking about compartment syndrome, don't only think about it in the context of trauma. All right? Now, what are they? Severe trauma, long bones. So, if you have a long bone fracture, say of the tibia or the forearm, especially, there can be trouble, as well as crash injuries. Crash injuries. Okay, when maybe a heavy object like a piece of metal, huge, falls on a patient's leg. I've seen cases where a car rolled onto the patient's legs and caused crash injury. And then if there's prolonged blood cut off, and then all of a sudden there's sudden return of the blood, so there's ischemia, and then for whatever reason, blood flow starts again. Realize that it causes what we call inflammatory swelling. So just think about patients who have post-op or patients who had a tourniquet placed very tightly and all of a sudden that tourniquet is removed. Okay. And then another risk factor is in patients who are anticoagulated. So patients on warfarin, patients who have bleeding disorders, patients who have developed muscle tear or vascular injury, and patients who have developed burns and systemic inflammatory response syndrome, and even patients who are going through resuscitation and they are bombarded with so much fluid. These are all risk factors of compartment syndrome. There are other less common causes of compartment syndrome like myositis, myonecrosis. So myositis is inflammation of the muscle. So whenever you hear itis, carditis, hepatitis, conjunctivitis, right? There's inflammation. So myositis basically means inflammation of the muscle. Then myonecrosis is death to the muscle, right? And then rhabdomyolysis is when the muscles are breaking down. For example, from drugs, from seizures, from exertion. Like the patient has a seizure. Like, so most of the time you realize that when patients have seizures, after the seizure, if you measure their CK levels may be up, right? And then patients who have had prolonged immobilization, whether they were intoxicated, post-surgery, even some bites and stings from some venomous animals can lead to swelling, and that swelling can then lead to compartment syndrome. And then high pressure injection injury. That's why I brought that in the question stem. For example, a patient with a paint gun, right? And then, at times you can set an IV line and then the IV will go interstitial. And if maybe it is in the night, nobody's actually checking on the patient receiving the IV, and the IV goes out of the vein and goes interstitial. And can you imagine if you are doing heavy, you are giving fluids, liters upon liters, and this thing goes interstitial? Oh my goodness, that can be very dangerous, right? And then soft tissue infections like necrotizing fasciitis, as well as intra-arterial drug injection, and even patients and babies who have difficult deliveries. Doctors, please, are you all following me? If you are following me, just type following. I want to make sure that we are all following before we move on and go through this thing step by step. If you are following me, just type following. Just type following, and then we'll take it from there. If you are following me, just type following. Dr. Bruni, I'm following you, so we can take it from there. Okay? Because I don't want to rush through anything. I want to make sure that we are going through everything step by step. All right? Following, Dr. Bruni, I'm following. Okay, good. So today I want to just make sure that you remember that compartment syndrome is not only about fractures. There are other things which can lead to compartment syndrome. Now, clinical features of acute compartment syndrome. Let's review some questions. Clinical features of acute compartment syndrome. Let's review some questions. You have a 28-year-old man who is admitted after a crash injury to the lower leg sustained during a workplace accident. Over the next several hours, he becomes increasingly agitated despite IV morphine. The leg appears swollen and firm. Dorsalis pedis pulse is 2 plus. Passive plantar flexion of the ankle elicits pain. Which of the following best supports the diagnosis of acute compartment syndrome? A. Presence of distal pulses. B. Worsening pain despite adequate analgesia. C. Elevation of serum lactate. D. Local erythema and warmth. And E. Bilateral leg swelling. Which of the following best supports the diagnosis of acute compartment syndrome? A. Presence of distal pulses. B. Worsening pain despite adequate analgesia. C. Elevation of serum lactate. D. Local erythema and warmth. And E. Bilateral leg swelling. And the correct answer is B. The patient develops worsening pain despite adequate analgesia, right? So pain out of proportion and unresponsive to analgesia is the most sensitive and early sign of acute compartment syndrome. It precedes neurological or vascular deficit. So if you're looking at the various clinical features of acute compartment syndrome, I know we talk about the 5 Ps. The first symptom you need to pay attention to is pain. Pain, pain, out of proportion. Pain, 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 out of proportion, right? Pain, out of proportion. So that's very critical. Okay. Next question. A 33-year-old man presents after falling from a roof. He has a closed tibial fracture. He's alert and oriented. 3 hours later, he becomes restless and complains of increasing pain in his leg. Exam reveals tense anterior leg compartment. Pain increases significantly when the toes are passively extended. Which of the following is the most specific sign? Doctors, now let's be careful. Which of the following is the most specific sign of acute compartment syndrome? Which of the following is the most specific sign of acute compartment syndrome? Which of the following is the most specific sign of acute compartment syndrome? A. Pulseless foot. B. Pain with passive muscle stretch. C. Diminished sensation. D. Pallor of the foot. And E. Edema of the leg. What's the correct answer? I can see a lot of doctors are going with B. Dr. Sekina, Dr. Sabine, Dr. Sekina, Dr. Farah, Dr. Cosmos. Everyone is going for B. And looks like we talked about it. So pain with passive muscle stretch. So pain on passive stretch is highly specific for acute coronary syndrome. Acute compartment syndrome. And it often appears early. Okay, it directly assesses the affected compartment muscle irritation. So pain on passive stretch is highly specific. By the way, what is the first sign of compartment syndrome out of all the 5 Ps? I want you to type it in the comment section right now. What's the first sign of acute compartment syndrome out of the 5 Ps? Out of the 5 Ps, what's the first sign of acute compartment syndrome? Please type it. And then after that, you will realize that what is the most specific or what is the most highly specific sign of acute compartment syndrome that becomes pain on passive stretch. Good. Dr. Cosmos got it right. Okay. Next question. You have a 41-year-old man. He's sedated and ventilated in the ICU following resuscitation for hemorrhagic shock after abdominal surgery. He received 10 liters of IV fluids in 24 hours. Nurses now note his right thigh is firm and swollen with no skin discoloration. CK level is 39,000 units per liter. Passive hip flexion causes tachycardia, which are the following most supports impending compartment syndrome. A. Intact femoral pulse. B. Hyperkalemia. C. CK more than 30,000 units per liter. D. Pain out of proportion. And E. Acidosis. I'm very happy about this question. I'm very, 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 very happy about this question because I got everybody from Dr. Ronin to Dr. Nomad to Dr. Noel to Dr. Babatunde to Dr. Titilope. I got everybody. I'm very, very happy about this question. Everybody, in fact, Dr. Elvis, Dr. Sifa, Dr. Theodora, I got everybody. You know why? Do you know why? This patient is sedated and is on ventilation. This patient is ventilated and he's sedated. Only Dr. Ronnie got it right. Dr. Ronnie and Dr. Danita, they are the only ones who got it right. This patient is sedated and he's on he's ventilated. That means he's unconscious. But you see, this is the mistake we make in our exam preparation. Yes, we know the answers. We know how these things go. Right? But, we know how these things go. But because we think, pain out of proportion, even in an intubated patient, med-cognitive people are saying, hey, it's the same thing. This guy is sedated. Look at the thing here, sedated, ventilated. He's in the ICU. Thank you very much. Dr. Sabine, Dr. Bruni, you tricked us. I didn't trick you. It was obvious. You were so quick. You were so quick. So the correct answer is C. CK levels more than 30,000 units per liter. That's the correct answer. Okay, that's the correct answer. And you realize that if you read the literature, in a sedated patient, direct pain reporting is not possible. So in a sedated patient, look, don't even look at pain. CK more than 30,000, muscle swelling, and autonomic pain signals, like if a patient develops tachycardia on movement, these strongly suggest muscle necrosis from acute compartment syndrome. So doctors, please, I know you've learned so much. I know you've prepared for this exam, but please look at the nuances. When I was setting this question, I was like, this thing, I like it. Dr. Nomad, I didn't trick you. I didn't trick you at all. It is what it is, right? We are learning, and this is good. Dr. Titilope, what she says, he says, yes, read with understanding and follow the lines in and out. Beautiful. That is it, right? That is it. Good. So now let's look at clinical features of acute compartment syndrome. Let's do a deep dive into it. So early signs of acute compartment syndrome can be very subtle, okay? Early signs of acute compartment syndrome can be very subtle. And physical exam alone is not reliable. In acute compartment syndrome, you have to note that you have to do serial exams because that is critical. And waiting in a case of acute compartment syndrome is not good because waiting in acute compartment syndrome is equal to muscle necrosis, muscle death. So be very careful. Don't wait in acute compartment syndrome. Okay? Now, the other thing I want you to remember that when we bring this friend of ours in Med-Cognito, it means you need to pay particular attention. What is the core clinical clue in acute compartment syndrome? It's pain. Pain out of proportion. Pain is the king, and everything else is just in the royal court. That's how I put it. Okay? So in acute compartment syndrome, pain progresses rapidly. And pain can go from mild pain to excruciating pain in a few hours. If you have a patient, your question stem is telling that you gave pain management, the patient is not getting better. You gave pain management, the patient is not getting better. Doctors, you've got to start getting worried. If you've given morphine to a patient, 2 hours later, the patient needs pain again, and you go like, but this thing doesn't look like this patient needs this much pain management, start thinking about things like compartment syndrome. So, pain is the earliest sign, but this is the most sensitive early sign, and you need to know it for the board exam. Pain with passive stretch. Pain with passive stretch is pathognomonic for acute compartment syndrome. Pain with passive stretch. All right. So stretching the muscle in the affected compartment, it hurts like fire. You've got a problem. So pain. So for example, you have a patient with trauma to maybe the upper arm, and then when, for example, there's finger extension, the patient says, "I have pain." Start thinking, there could be a component of compartment syndrome which is brewing, or if the patient has pain with passive dorsiflexion, where that means that there's stretching of the anterior compartment, that means there's a problem. Another thing you also want to look at is that muscle feels like rock hard sausage, then there's a problem. It feels like rock hard sausage, then there is a problem. Okay. And if there are neurovascular changes, but remember, the neurovascular changes are late signs. So the early sign is the pain. Neurovascular changes are late signs. Let me say it again. Pain is the earliest sign. But which kind of pain is pathognomonic? Can you please type it in the comment section? Which kind of pain is pathognomonic? Which kind of pain is pathognomonic for acute compartment syndrome? Doctors, which kind of pain is pathognomonic for acute compartment syndrome? I want to know. Which kind of pain is pathognomonic for acute compartment syndrome? Let me know. Which kind of pain is pathognomonic for acute compartment syndrome? Pain with passive stretch. Thank you, Dr. Ibironke. Pain with passive stretch is pathognomonic. Now, of all the late signs, which of them is the earliest late sign? Is paresthesia. 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 Now, the patient can also have reduced 2-point discrimination or light touch, and there can also be muscle weakness. As soon as you start seeing muscle weakness, that's a bad sign. Okay. Now, the pulselessness that we talk about, the 5 Ps, pain, pulselessness, paresthesia, all those things, that pulselessness is a very, very, very late sign. Pulselessness is a very late sign. So pain on passive stretch, if you're looking at the late signs, the earliest late sign which should point you to compartment syndrome is paresthesia. So always remember that paresthesia precedes pulselessness. These are very critical pointers that you need to know. Okay, these are very critical pointers that you need to know. So Dr. Eno Akpala says pain with passive stretch. Yeah, that's good. So remember that paresthesia will always precede pulselessness. As soon as you get to the level of pulselessness, it's almost game over. It's almost game over for the patient. What are other alarming signs of acute compartment syndrome? These signs suggest that damage is already underway. It looks like the muscle damage is already going on. If there's sudden or excessive limb swelling, if there's acidosis, if there's hyperkalemia, right? If there's a rhabdomyolysis with CK levels more than 30,000 units per liter, if the patient starts developing rhabdomyolysis and CK levels start rising, that tells you that myoglobin is leaking from the muscle into the bloodstream. That means myoglobin is leaking into the bloodstream. Okay, so let's do a quick recall. I'm coming to the 5 Ps. Oh, Dr. Bonnie, I know my 5 Ps. I know my 5 Ps. But in a board exam, I'm not going to ask you what are the 5 Ps. I'll ask you what kind of pain is pathognomonic. In terms of paresthesia and pulselessness, which one will come first? Those are that tells you that you are trained, right? That tells you that you are really prepared for this exam. And that tells you that you've been to MedCognito lectures. So the 5 Ps are pain, pallor, paresthesia, paralysis, and pulselessness. And then there can also be 3 Rs. Now, those 3 Rs tell you that it's almost game over. So if there's rapid girth increase or rapid increase in the size of the muscle, rhabdomyolysis with increasing CK levels, right? And then reperfusion signs where the patient has developed acidosis or hyperkalemia, then you know there's a problem. So these are the 5 P's, and add your 3 R's. Please, I need you to write this down because I'm going to do active recall after this lesson. We are going to do active recall after this lesson. And this time, I'll not provide you any answers. You need to give me your answers, right? So please, make sure that you've mastered your 5 P's and your 3 R's so far as acute compartment syndrome is concerned. Now, what are the initial measures and management in patients with acute compartment syndrome? What are the initial measures and management of patients with acute compartment syndrome? So let's start with a question. You have a 37-year-old woman with left forearm crash injury. She's receiving fluid resuscitation in the emergency department. Her pain worsens significantly over 2 hours. The attending physician or the attending others measuring compartment pressures. Which of the following is the most appropriate approach? A, delay until a vascular surgery consultation is available. B, use a Doppler probe and compare flow across compartments. C, insert an 18-gauge needle connected to a pressure transducer. D, order a venous Doppler to rule out DVT. And E, administer mannitol and measure and remeasure in 2 hours. What's the correct answer? What's the correct answer? What's the correct answer? What's the correct answer? So this one, the correct answer will be C. You know, you want to insert an 18-gauge needle connected to a pressure transducer, because the standard method for measuring compartment pressure includes using an 18-gauge needle with a pressure transducer setup. And this is accurate and practical. Now, there's a calculation we can also use. And what I will do is I'll take my time, do a whole video on it too, and then I'll load it for you as well. How to calculate compartment pressure using diastolic blood pressure. I'll take my time, do a whole video on it, and then load it for you as well. Okay? So I promise you that I'll work on that for you. Now, you have a 10-year-old boy with a circumferential 3rd-degree leg burn. He's now complaining of excruciating leg pain 4 hours after resuscitation. The leg is pale, it is firm, and cool with weak pedal pulses. What's the most appropriate initial intervention? A, administer additional opioids. B, apply a compression wrap. C, perform escarectomy to relieve constriction. D, measure serum lactate and CK levels. And E, elevate the leg and apply cooling. What's the correct answer here? What's the correct answer here? I see a lot of doctors are going for C, perform escarectomy to relieve the constriction. Remember, this is a circumferential burn, so you want to perform an escarectomy. So please, you also need to know the difference between escarectomy and fasciotomy. Escarectomy is done for patients with circumferential burn, right? So this is the limb. There's a burn which goes around the limb. So you perform escarectomy. You remove the eschar. Fasciotomy is done for patients with compartment syndrome. I'll show you a picture. Okay, so please don't confuse the two. Escarectomy is to burns, as fasciotomy is to compartment syndrome. Let me say it again. We have a difference between escarectomy and fasciotomy. Burns can lead to compartment syndrome. But if the patient has circumferential burn, what you need to do first is escarectomy, right? So escarectomy is to burns, as fasciotomy is to compartment syndrome. Okay, next question. So you have a 29-year-old man with tibial fracture. With a tibial fracture is being monitored for signs of acute compartment syndrome. Initial exam is normal, but he reports increasing pain and tightness in the leg over the next 2 hours. Passive stretching now causes severe pain. The orthopedic team is contacted. Which of the following actions is most appropriate while awaiting the surgical team? A. Apply ice packs and elevate the leg. B. Immobilize the leg with a circumferential plaster. C. Keep the limb at heart level and continue reassessment. D. Delay any intervention until pressure measurements are taken. And E. Begin empiric antibiotics and await MRI findings. What's the correct answer? Dr. Bironke, thank you very much. She says escarectomy. So escarectomy, add that it has to do with circumferential burns, right? Fasciotomy is for compartment syndrome. Doctors, unless you keep doing these things, learning them all the time, you'll miss some critical things, right? I know you are awesome physicians, no doubt, from all over the world, powerful. But some of us, it's been a long time. You did actual academic medicine, right? Studying for a board exam. If it comes to managing the patients, you know exactly what to do. But board exam, so that's why we are here to guide you, okay? That's why we are here to guide you. Correct, Dr. Bironke, you've corrected it. That's beautiful. So the correct answer is that to keep the limb at the heart level and continue reassessment. While awaiting for surgical input, the limb should be kept at the heart level. That is C, okay? To maintain perfusion. Continuous reassessment is critical. So in a patient you're suspecting acute compartment syndrome, don't just assess once and go. No, you need to reassess the patient, assess all the time. Okay, so now the deep dive here is this. If the pressure is too high inside that compartment, it kills the contents of the compartment, like the muscles, the nerves, the vessels. So in the board exam, there are 4 things so far as compartment syndrome is concerned that you want to pay attention to. 4 things. You want to normalize the flow of blood into the compartment. You want to release the pressure on the compartment. You want to then measure how bad it is. And you want to keep reassessing constantly. Let me say it again. In a board exam, you want to normalize blood flow. You want to release the pressure. You want to measure how bad it is. And you want to reassess constantly. Okay? Dr. Sabine, you asked that I show you the previous slide. This is the previous slide. Okay? All right. So, step 1, restoring normal blood flow, where I call it filling the pipes. Okay? So allow the blood to flow. Allow the blood to flow. Allow the blood to flow. Doctors, allow the blood to flow, right? So fill the pipes. Allow the blood to flow. Allow the nerves to be free. So fluid resuscitation if patient is hypotensive or is in shock. Okay? And realign fractures, because at times when you realign it, it helps to reduce all the pressure which is building up. Number 2, remove external pressure. So if the limb is tightly wrapped or squeezed, free it immediately. So for example, if somebody puts on a plaster of Paris or something, remove it. Okay? Or bivalve or remove the cast. So cut here, cut there, so that it becomes free. And escarectomy for circumferential burns, because a burn can serve as a tourniquet and it can be cutting off blood supply, right? Okay, good. Now, someone was asking me, how do we measure compartment syndrome? So that is the manometer which we use to measure compartment syndrome. So you just put it in, and if the absolute pressure is more than 30 millimeters of mercury, then there's compartment syndrome. Now, as I said, there's a calculation as well that we can do, and I'll take my time to walk you through it in a separate video. Okay, so you can learn how to use diastolic blood pressure to calculate a patient's compartment, because you'll be giving the compartment pressure and you'll be giving the patient's diastolic pressure, and you should be able to tell does the patient have compartment syndrome or not based on the information you are given. Okay, we'll do that. Now, someone was also asking me, how does fasciotomy look like? This is how fasciotomy looks like. This is how fasciotomy looks like. So you actually cut through it so that you can relieve the pressure. Most of the time, it's the person who is going to perform the fasciotomy who should also be measuring the pressure. But don't wait for numbers if the diagnosis of acute compartment syndrome is clear. Acute compartment syndrome is a clinical diagnosis, okay? And then always make sure that you are reassessing the patient regularly. Don't just do a one-time exam. Dr. Rockefeller, this is the previous slide. Okay. All right. So make sure that you are re-examining the patient all the time. So quick review. Make sure that you do your free resuscitation. Make sure that you immobilize the limb and align the fractures. Make sure that if there are any cast or constrictive dressings, you remove them. Make sure that you monitor the neurovascular status. Make sure that pressure measurement is done if you're unsure. Make sure that you get the surgeon involved early. Okay. Make sure that escalating if there are burns, and then make sure that there is serial reassessment of the patient. And if there should be fasciotomy, it is done. This is my quick point review for these things. So now let's look at fasciotomy and further management. Okay. What Dr. Rockefeller says, and the one before that. Doc, maybe let me just do that quickly. I think it's this one. And this one as well. And this one. This is the how to measure the compartment pressure. And this is the last one. Okay, sure. Okay, now we can move on. So let's do fasciotomy and further management in a patient with compartment syndrome. So let's deal with this question. You have a 26-year-old. You have a 26-year-old athlete who presents with tight and painful right forearm after intensive weightlifting. On exam, the forearm is mildly tender and sensation is intact. Passive stretch elicits minimal discomfort. The physician is unsure whether this represents evolving acute compartment syndrome. What's the best next step? A, immediate fasciotomy. B, observe and reassess every 4 hours. C, hourly neurovascular exam and repeat pressure measurements as needed. D, CT scan of the forearm. And E, administer mannitol and assess response. What's the correct answer? What's the correct answer? What's the correct answer? Doctors, don't forget that you can still send me a message on WhatsApp +1306 891 5649 +1306 891 5649. Usually after the class, a lot of people make a lot of inquiries, and tonight you have a class as well. So if you want to join tonight's class, this is the best time to get in touch, get registered so that you can join the class tonight. Okay. So the correct answer will be C. Okay. Hourly neurovascular exams and repeat pressure measurements as needed. In low clinical suspicion cases, you should observe carefully, reassess hourly, and repeat pressures if the signs worsen. Remember that fasciotomy is not appropriate without high suspicion or pressure data, because fasciotomy is a big thing. It's a big procedure you're going to do. So make sure that you are sure. Okay. Now, the only recognized treatment for compartment syndrome is fasciotomy. That is like definitive treatment. And early fasciotomy can help to save the limb. All right. So when are you going to do fasciotomy? When there's a clinical suspicion of compartment syndrome and when the compartment pressure in the compartment is more than 30 millimeters of diastolic pressure, then you want to do your fasciotomy. So remember, fasciotomy is the definitive treatment. However, if you have a patient who suspects compartment syndrome but has a cast on, remove the cast or do a bivalve of the cast, right? If there's an esca, or if the patient has suffered a burn, make sure that you do your escarectomy. What are some of the contraindications of fasciotomy? Late compartment syndrome. Late compartment syndrome. Because remember that Tissue damage becomes irreversible 4 to 8 hours after compartment pressure has increased. So if you don't act quickly, we are in trouble. And fasciotomy for established acute compartment syndrome after 6 hours of onset increases the rate of infection and amputation. So if you wait, dilly-dally, and you don't act fast, and eventually you go on to do your fasciotomy after about 6 hours of compartment syndrome, that increases the rate of infection and amputation. Okay, doctors, so it's time for me to also quiz you. Active recall. But before active recall, as usual, in MedCognito, you have all these available for you. Every single portal has something unique that you need to review. Okay, so from ophthalmology to cardiology to respirology, in MedCognito, all this is done for you. So like even this compartment syndrome, it's already reviewed in the emergency medicine portal. You just go in there and review it. You have line upon line review of every objective. Okay, you have 14 live classes every month, and I need to arrange with the teachers so that we run this month's med drill as well. Okay, in total, when I look at the number of live classes you are doing 42 hours of live tutoring every single month. So even if you are so tired and you just keep showing up in class every month, know very well that you are studying with us in class alone for 42 hours. Okay, you also have mock exams in your portal that you can do, and then every 2 weeks as well, we will do a live mock exam for you. And you have your personalized study portal so that you can navigate and then go to every part. So it's otorhinolaryngology, ophthalmology, pediatrics, gynecology, whatever topic you want to review. So far as the objectives are concerned, you can do that. And in Med Bullets alone, we've reviewed 3,400 topics for you. So 3,400 topics, this is in Med Bullets. So this is like your final revision. But I tell people that don't wait 2 weeks to the exam before you start doing your Med Bullets. Don't do that. Start Med Bullets from the very first day you register. And where can you find Med Bullets? Med Bullets are found in the family medicine portal of MedCognito portal. So right from the word go, as soon as you start today, bam, start reviewing Med Bullets and do about 10 Med Bullets every day. If you do 10 Med Bullets, remember every one Med Bullet contains 10 topics. So if you do 10, that means you are reviewing 100 topics. And you can do 10 Med Bullets in, say, 1 hour, 40 minutes. So the way Med Bullets are designed, it's specific. So for example, like today we did compartment syndrome, right? What's the definitive management step for compartment syndrome? Boom, fasciotomy. Next Med Bullet. What is the earliest, or what is the pathognomonic pain feature of compartment syndrome? Pain on passive extension, like those kinds of things. So, and we've done 3,400 of them for you. So if you want your final revision for the exam, for those who are going in the August, September, this is the time. Jump on. Med Bullets are there. And in fact, you can even just plug into MedCognito and study synchronously, because you can just be learning on your own, because every lecture you need is there. Every replay of every class is there. Even for 1 month, you still get access to everything in MedCognito. Everything. So if you look at the total value, it's about 7,860, but we've brought everything down so that we can help as many people as possible. It's 2,199. However, if you can't, even if you say that I want to pay monthly, you can do that at $420 every single month for 6 months. Okay. Now, for those who have already finished the 6 months, you can even renew for a week. For example, if you just need 1 week to renew, 2 weeks to renew, 1 month. All right. You can just give me a call and we can help you with all those things. So, doctors, I hope we are in exciting times and I hope you are very happy about it. So, let's get ready to rumble for the active recall. I'm going to hide myself I'm going to hide myself here. And then let's start with the active recall. So please, I'll give you 5 seconds for the first question. Why is increased pressure dangerous in the muscle compartment? Just type your answer quickly. Why is increased pressure dangerous in the muscle compartment? Why is increased pressure dangerous in the muscle compartment? Why is increased pressure dangerous in the muscle compartment? And the answer is that it compromises perfusion, it leads to ischemia, nerve damage, and muscle necrosis. Okay, beautiful. Dr. Bironke, thank you. So that's why I'm saying during the rapid review, you need to type quickly. Okay, good. Next question. What are the most common causes of acute compartment syndrome? Please type quickly. What are the most common causes of acute compartment syndrome? What are the most common causes of acute compartment syndrome? Most common causes of acute compartment syndrome. What are the most common causes of acute compartment syndrome? So Dr. Angelica or Dr. Babatunde says, would love to join and pay. Want to write in January 2026. Sure, Doc, that's fine. Just send me a message right away. Then after the class, I'll give you a call, okay? And then we can get you going. Okay. Okay. So what are the most common causes? Long bone fractures and crash injuries, right? Long bone fractures and crash injuries. We are talking about the most common causes. Remember, common things are common. Common things are common. Common things are common. Common things are common. Next one. Name at least 3 non-traumatic causes of acute compartment syndrome. Acute compartment, non-traumatic cause of acute compartment syndrome. Please type in your answers. Non-traumatic causes of acute compartment syndrome. Type in your answers, doctors. Non-traumatic causes of acute compartment syndrome. Please type in your answers. Non-trauma causes of acute compartment syndrome. Non-trauma causes. Okay, I see that Dr. Eno says warfarin. So spontaneous hematoma on patients on anticoagulants. So like rivaroxaban, dabigatran, apixaban, warfarin, low molecular weight heparin, unfractionated heparin, as well as IV extravasation, as I said, if the IV goes interstitial, and then high pressure injection injuries, right? And then bites and stings, as well as rhabdomyolysis. Rhabdomyolysis. Okay, next question. Oh my goodness. What's the significance of burns in causing acute compartment syndrome? Circumferential burns, they can restrict expansion of swollen tissues, acting like a tourniquet, right? So this is where you do your escalating. Okay, what's the most sensitive early clinical feature of acute compartment syndrome? What's the most sensitive early clinical feature of acute compartment syndrome? Please type your answers quickly. What is the most sensitive early clinical feature of acute compartment syndrome? What's the most sensitive early clinical feature of acute compartment syndrome? Type your answers. What's the most sensitive early clinical feature of acute compartment syndrome? I want to see your answers. What's the most sensitive early clinical feature of acute compartment syndrome? Dr. Ariel says pain on passive stretching, pain on passive stretching, pain on passive stretching. So that's pain out of proportion to the injury, especially pain with passive stretch. Beautiful, beautiful. What are some late signs of acute compartment syndrome? Let's go. What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? I want to know. What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? What are some late signs of acute compartment syndrome? Paralysis, pulselessness, reduced sensation. Good. So I see people are typing it there. So now don't just lump all the 5 P's together, right? What are some late signs? You need to know. 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 Okay. What should be done first in suspected acute compartment syndrome with a cast? What should be done first in suspected acute compartment syndrome with a cast? What should be done first in acute compartment syndrome with a cast? Tell me. What should be done first in a patient with acute compartment syndrome with a cast? What should be done first in a patient with acute compartment syndrome with a cast? What should be done first in a patient with acute compartment syndrome with a cast? Good. Bivalve the cast or remove the cast immediately. Good. What is the only definitive treatment for acute compartment syndrome? Only definitive treatment. Only definitive treatment. Doctors, tell me. Only definitive treatment. By the way, doctors, I have a question before we move on. What is the only definitive treatment? I have a question. The active recall we've added, is it helpful? Do you like it? Don't you like it? I really want to know. Okay. The active recall that we've started doing, do you like it? Dr. Brony, I don't like it. I don't like it. You know, I just want you to focus on the class. Do you like it at all? The active recall that we are doing. Do you like it? Okay, sure. So people are saying yes. Good. Okay. Okay. All right. So if you like it, then that's good. So what's the only definitive treatment? Yes, that is fasciotomy, right? Okay. Is it appropriate to delay fasciotomy for imaging studies like MRI or CT scan? Is it appropriate? Is it appropriate to delay? Is it appropriate? Okay, good. So no, imaging delays treatment and is not necessary to diagnose acute compartment syndrome. Beautiful, beautiful, beautiful. Next question. When should fasciotomy ideally be performed? When? When should fasciotomy be performed? When should we perform fasciotomy? When? When should we perform fasciotomy? When? When should fasciotomy be performed? When? When should fasciotomy be performed? Within 4 hours of symptom onset, because after 6 to 8 hours, tissue damage may be irreversible. Okay? Because after 6 to 8 hours, tissue damage may be irreversible. So within 4 hours of symptom onset, do fasciotomy. So doctors, it's been an awesome class. Thank you very much for spending your afternoon with me. Again, you can reach out to me at +1. That's my number scrolling at the bottom of the page. +1 306 891 5649. +1 306 891 5649. Reach out. We'll help you. We'll guide you, especially for those who want to join today's class. Reach out right away. It's only $420 every month for 6 months. So reach out. Let's get talking. Let's get everything going. Okay. I'm going to catch some rest, but I'll be ready to talk to everybody who texted me or who calls me. So if you also want to reach out and you want to call me right away, do that. And let's get on before other people take your spot. Okay. All right. Okay. Someone is asking, please, when is the next class? It's my first time here and I really enjoyed it. So the next class is tonight. Let me just check the time for you. The next class is tonight. The next class is tonight. And Doc, you can just send me a WhatsApp, okay? And we'll talk. The next class is tonight at 6:30 p.m. EST. So now it is almost 3:30 p.m. So in 3.5 hours, the next class is going to start. Tonight is 3:30 p.m. 6:30 p.m. EST tonight. Okay. So, doctors, if you have any question, reach out to me. I'm here for you. Give me a call right away, and we'll be here to help you. Au revoir. Thank you, thank you, thank you, thank you, thank you, thank you, thank you. And don't forget to master your compartment syndrome. All the best. Good day. Bye-bye.